to obstetric care during COVID-19. Just a quick few housekeeping items before we get started. The session will be recorded and available on our website, which is at www.mcpapformoms.org. A copy of the PowerPoint slides will be available on the MCPAP for Moms website as well, under Tools and Resources page. Our presenters will stop for questions during several points during the presentation, and there'll be time at the end to ask questions. If you have a question or comment, please type the question into the question box at the bottom during the presentation, and we'll read your question or unmute your line to enable you to ask your question. You'll receive a brief survey following the presentation, and we appreciate your feedback and help us improve future presentations. So today's presenters are Dr. Nancy Byatt and Dr. Leena Mittal. Dr. Byatt is a physician scientist and a perinatal mental health expert who is focused on improving mental health care systems to promote maternal mental health. She is an associate professor of psychiatry and OBGYN and a quantitative health scientist at the University of Massachusetts Medical School. She is an inaugural medical director of MCPAP for Moms, a statewide program that has impacts the state and national policies regarding perinatal mental health and increases access to perinatal mental health for thousands of women. Dr. Byatt has several federal grants that focus on developing and testing interventions for addressing depression in obstetric settings. She frequently serves on the national advisory boards and as an expert for work groups focused on improving perinatal mental health. Her academic achievements has led to over 100 peer-reviewed publications, book chapters, and national presentations, and numerous national awards. And then Dr. Leena Mittal is an instructor at Harvard Medical School and the director of Division of Women's Mental Health at Brigham and Women's Hospital. She specializes in treatment of perinatal mental health and substance use conditions. She's a graduate of the Harvard Longwood Psychiatry Residence Training Program and has completed a fellowship in psychosomatic medicine at Brigham and Women's Hospital. Dr. Mittal is a board certified in psychiatry, psychosomatic medicine, addiction medicine. Her clinical and academic interests include collaborative care for complex perinatal patients with mental health and substance needs, including integrated treatment for pregnant and postpartum women with opioid use disorder embedded within perinatal settings. Dr. Mittal is a committed educator, teaching medical students, residents, and fellows about the program of Women's Mental Health Fellowship Program at Brigham. So welcome both of you, and I will let you take it away.
Thank you, Beth, and thank you to those who've joined. So I'm going to start off. As Beth said, we're going to talk about integrating mental health care into OB settings in the context of COVID. And so I'll be doing the first portion of the talk, and then Leena will do the second portion of the talk. So I know we're all aware of this, so how we provide care has dramatically changed over the past few months. You know, the patients that we're seeing have changed, and how we're providing care has changed. So, I mean, for us as psychiatrists, we're often seeing people using telepsychiatry in OB care. That's obviously a lot more difficult because there's a lot of things that you can't do, and a lot of care has been delayed, but clearly delivering babies cannot be delayed. That's something that needs to be continued, and it's not something that is not an elective procedure. So I know that all, of you, particularly those of you who are providing obstetric care and working in obstetric settings, have had to navigate this challenge where you needed to provide care in the context of really, really rapid changes. And next slide, please. And as you're doing that, connecting with patients, connecting with others has become really challenging. And part of this is obviously impacting women's mental health too. So we used to be able to actually connect with each other. You'd be able to look show your patients your facial expressions. Even if you are seeing them in person, now it's done with a mask. It just creates many challenges. And, we're using Zoom, we're using teletherapy, but as evidenced by this slide, it's not always working. It doesn't always work great, right? And not all patients can even access those resources, because a lot of women don't necessarily have access to internet or can't necessarily do a virtual visit. So this has all become extraordinarily challenging. Next slide, please. And so it's been an adjustment for everybody. And while we have, and for all of us in healthcare and throughout the whole world, we're all experiencing and adapting this traumatic event, and then also helping the women, the families that we serve to also do that. So it's a sort of double challenge where we're experiencing this ourselves, but then also having to adapt our work environment and serve patients who are also adapting to this challenge. And so the goal of this webinar is to give you some concrete strategies for how, when you're working with pregnant and postpartum, we can help address their mental health in the context of all these changes. So I'm going to give you a case example of actually a call we got recently in MCPAP for moms that really exemplifies sort of one thing that we're really seeing really frequently. I've been both seeing when I'm interacting with women and also providers. And it exemplifies this, what we're seeing of a lack of delayed screening and a delayed recognition of women's mental health conditions. So we got a call recently actually from a pediatrician who was calling, and she was asking about, she had a few questions. One of her questions was she described a patient who actually had developed postpartum psychosis. And she felt like, in the past, this was often picked up in the OB floor because they would be on L&D, and they would have been there for a few days and it would have been noticed. But this patient had left really quickly, because a lot of women are leaving after when they're postpartum, they're leaving the hospital really quickly. And in this particular case, the pediatrician had picked it up, and it ended up kind of causing ended up getting caught at a time when the pediatrician felt like if we had the care we had before, the crisis could have potentially been prevented. It would have been picked up earlier. The other thing this pediatrician was mentioning was that they're noticing that they felt like they really had to be screening patients more often, and they were really calling, asking, how can we increase our screening? Because they were noting that women were, they were either afraid to go back to their OB because they're worried about the baby, and they felt like, but they tend to prioritize the baby's health, so they are still going to the pediatric setting. So we've noticed an uptick in calls from pediatric providers, and part of this is them feeling that, they feel like women are going to go to them and not necessarily their OB. So this is kind of one of these tricky things. I'm going to give you some kind of examples of ways that we've been learning of people that are continuing to screen for mental health. So I gave you a couple of examples postpartum. What we've also been hearing about is a major challenge in how do you screen patients in the OB setting when some visits are still happening in person, right? But a lot are happening virtually, and that creates a ton of challenges for how do you actually administer that screen, how do you do that virtually, and so forth. Next slide, please. So as I've mentioned, the usual screening is a lot more challenging. There's fewer in-person visits, and the exchange of screening tools can be difficult, especially if you're doing that via paper and pencil. And there's also various variable access via patient portals. Not all patients have the patient portal. Not all women have access to the internet. So doing this has also the potential to have the potential to be worsening disparities, because not everybody necessarily going to have access to some of the tools that are available for screening. Next slide, please. So we're going to do a poll here to ask you some questions about this. So are you screening for mental health and substance use disorders? So we're really curious to hear from you. Are you screening less prior to the pandemic, same as prior to the pandemic, or more than prior to the pandemic? The answer should come up, right, Sarah?
Yep, I'll give it a few more seconds and we'll close it.
Okay.
Okay.
So same. Oh, this is good. So I'm really pleased to see this. This is wonderful. So that's great. It sounds like those of you who are on the call have figured out how to do this the same, if not more. And that's great. I'm going to give an example, which I believe is on the next slide, about one of the things that one of our colleagues actually at UMass, where I'm located, is doing around screening. So this is what we're doing at UMass. I can't take credit for this. My colleague, Dr. Moore, Tiffany Moore-Simus, has initiated this for the OB department at UMass. And this just kind of gives an example. So what they do is they do have a face-to-face visit for the initial OB visit, and they do the EPDS, and they have actually added the GAD-7. They also use the NIDA, which is the NIDA quick screen for substance use disorders. The GAD-7 is a screening tool for anxiety that is validated for use in pregnancy and postpartum. It's a quick screen. It's 7 questions. And one thing we've heard a lot from obstetric providers and also pediatric providers is, how do we tell what's anxiety? Everyone's anxious about COVID, right? It'd be weird not to be. So how do we tell the difference between anxiety about what would be expected anxiety versus what may need treatment and what we may need to refer for actual treatment? And so that's been pretty hard to navigate because so many people are anxious about this. So one thing that we've heard from some colleagues they found helpful is to be adding the GAD-7 to screens to screen for anxiety. And in this particular practice, they're doing that on paper and also, and then it's entered into the EMR. So also at 28 weeks, they do the same thing. So that, again, they added on the GAD-7, which is something that you may want to consider. And then the other thing that has been done at UMass is they also, they added on a virtual 2-week visit, partly getting at what I was just describing with what we're seeing with pediatric providers observing and kind of women feeling, like the care drops off, and that's a lot of because of the systems issues. And so they added on a virtual visit and where they screen with the EPDS. And then they also do the GAD-7, and they do that verbally on the phone. And the nice thing about doing it verbally on the phone is it doesn't rely on a patient portal where not necessarily everyone's gonna be able to access that, right? Because not everybody has the skill set or the internet access or so forth. And then at 6 weeks postpartum, they do the EPDS and the NIDA, and they're adding on the GAD-7. They do have a virtual visit then. And they do this verbally, and again, enter it to the EMR. And it was interesting, I actually myself, my son had a telepsych visit, not telepsych, a pediatric visit recently, and they did with the child behavior checklist verbally, and it was fine. So it's interesting, because I think that's what a lot of people are doing. They're doing these things verbally over the phone before visits. And then also they're doing it PRN if there's expressed symptoms. So for example, if a patient screens positive on the GAD-7, the EPDS, or the NIDA, and you want to follow up and see how they're doing, we have always typically at MCPAP for Moms recommended, if you start a medicine or they've screened positive, to follow up that, because the goal is always treatment to remission until the symptoms go away. So we also would recommend, that this can continue to be done either in virtual visits or in person to continue to screen them and follow up just like you would any illness. Like if you screen positive, the patient screens positive for diabetes, you'd want to follow up, and you want to be following up and making sure their blood sugar is under control, right? So similar concept with depression and anxiety and substance use disorders, where if someone screens positive and you're providing treatment or you refer for treatment, you want to follow up that and make sure that they're getting better. And so we'd recommend doing that as needed for follow-up and monitoring. And then in pediatric settings, as I described, a lot of pediatric settings are also screening and adding this on, and also some of them are adding on the anxiety screen as well. Next slide, please. So other things that you can do as providers when we think about that, when we think about COVID and serving your patients, is being aware of, as I talked about, screening for depression, anxiety. I talked about screening for the GAD-7. I also just want to let you know that we have the MCPAP for Moms OB Provider Toolkit has algorithms for this that may be helpful. The Lifeline for Moms OB Provider Toolkit, which was developed at UMass in collaboration with MCPAP for Moms, that has actually some brief screening measures that could be either administered verbally, or you could take these measures and put them in the EMR, or you could do them hand paper. It actually has in it, that's a link to the website, and we'll put it up at the end. It's available on lifelineformoms.org, and it's the OB Provider Toolkit, and it has in it the GAD-7 for anxiety, it has the EPDS for depression, and it also has in it the MDQ for bipolar disorder. It does not have a substance use screen, but we do recommend adding the NIDA quick screen. And then it also has a short screen for PTSD. So that's something that you may want to be familiar with, and it also has some algorithms, how do you respond to those screens. So that's another tool that's out there that may be helpful. And of course, we're available. We're available virtually. We are doing telemedicine visits with women we've been, I think, probably doing more face-to-faces than before because the severity we found has increased. And so we're still available. We're happy to speak with you. And we are certainly doing telepsychiatry visits. And if the patient can't do telepsychiatry, then we're doing them over the phone because we don't want lack of ability to telepsychiatry to interfere with access. And, you know, all of this information is available at these websites. So, and, you know, as we talked about, some of the reasons patients are falling through the cracks is this hard to access healthcare. A lot of times also, we've had several calls from providers who say the patient can't use her prior coping mechanisms. A lot of that might be going for walks. It might be seeing family. You know, we always say it takes a village, and now it's like, you can't have a village join you during these times of social isolation. And then as I talked about, women leaving the hospital quickly. And so, next slide, please. And knowing that, you know, especially with these, that women may feel as if they can't access some of these coping skills that they may have used before, there still are a lot of things women can do. And so we have developed some resources both for you to be able to use to be able to, when you're serving women, and also for women themselves. And of course, we can always consult with you. And these materials are specific to COVID. So this is what we developed. So we developed a patient handout called, this is a patient-facing handout meant to give to patients, taking care of yourself during COVID. One has just things specific to COVID, and also has a self-care plan that women can actually complete. These are available on our website. We welcome you to download them, hand them out to your patients. And whenever we do a face-to-face evaluation through MCPAP for Moms, our virtual face-to-face now, we give these materials to women as well. We also developed a handout for that's actually summarizes a lot of the information that's in this webinar that's provider-facing material. We welcome you to download this from our website and give it to colleagues, and you know, let people know about this. We developed this all since COVID. It's all COVID specific. So now I'm going to pass it along to. If people have questions, please let us know. And now Dr. Mittal is going to do some other case examples and talk about trauma-informed care and substance use disorders. Thank you.
Thank you so much, Nancy, and thank you all for attending and for really engaging around this issue in this kind of complex time. So I wanted to kind of start with another case, a case sort of adapted from one that we saw a few weeks ago, so quite into the midst of the and into the thick during the sort of peak time of high prevalence of cases of COVID, and really kind of just think a little bit about how care kind of was altered and what the birth experience is like for this one mom. So I received a call from an obstetric provider who was really, really concerned about a mom who was about 9 days postpartum, and she was having a pretty significantly distressing symptoms, and had a really complex birth experience. So she had just left the hospital recently and called her obstetrician because she was having incredibly scary, distressing, intrusive thoughts about harm coming to the baby, and unable to sleep since she had gone home, and struggling pretty significantly. Her birth experience and her postpartum experience were really impacted by the fact that she herself was COVID positive. Her husband was COVID positive and symptomatic at the time of the birth, and so she had been, and so was all of her extended family, because she lived in a setting where she was very close with her family, and so there was really very little support available to her during the course of her delivery, and so she ultimately ended up delivering alone. Because she was a person who had a confirmed COVID positive test, she had a shared decision-making process with her obstetrician and the newborn medicine folks, and decided to be separated from her baby, though that was really a complicated experience because then she had some post-operative pain, and she had really limited help in her her postpartum room. She had really limited contact with healthcare providers because that's an experience that's really common for women who are COVID positive. It's really complicated for the healthcare providers to go in and out of the room, so they're going less often. They're responding less to the calls and less quickly because of all of the PPE. And she also, this was her first baby, and she had really very little time to connect with, learn how to care for, bond with her baby. So she went home and felt incredibly distressed and called her OB, describing images that were really distressing to her about harm coming to her baby. Some of them were very gory and scary, and also this inability to sleep and feeling like she was, quote, going crazy. The obstetrician was able to give us a call, and we were actually very fortunate in this time of telehealth, excuse me, to be able to actually do a face-to-face evaluation with her really quickly, because the obstetrician was very concerned about this safety question. And so we ended up seeing her and really being able to engage her in mental health care relatively quickly, and ultimately sort of diagnosed what we were seeing or hearing about as an acute stress reaction or trauma-related syndrome. Next slide. So poll, another poll. Have you been seeing more women present in your practices with depression or anxiety since COVID-19 during the pandemic? Either no, less than prior to the pandemic, the same as prior to the pandemic, or yes, there's more. And Sarah, just let us know when.
Sure, I'll give it a few more seconds and then end the poll.
Yeah, so I think that as we're hearing and seeing on our end, where we're receiving calls from some of you and some of your colleagues, we're seeing the same thing, that there is a greater volume of mental health symptoms being acknowledged, and then also a sort of acuity or severity that's also folded in. Thank you. Next slide. So, one of the major risks I think this pandemic has brought forward is that in the context of all of the pre-existing stress and anxiety that may be happening, there's also this risk that the birth experience itself may be perceived as traumatic at perhaps greater rates than we were seeing prior to the pandemic. And that's owing to the fact that, as Dr. Byatt described, the practices around labor and delivery have changed. The worry about what the experience will be like is greater going into the process. The supports during and after are different. And so in some of the risk factors that we're seeing and that are sort of borne out in conversations with our colleagues are that, anxiety prior to labor, absence of a birth partner, feeling disconnected, helpless, or isolated during the labor and birth process are all risk factors for having trauma-related symptoms or experiencing the birth process as traumatic inherently. And all of these things are sort of highlighted and exacerbated during this complex time. Next slide. So some of what we're seeing and what we can do, especially in thinking a little bit about, kind of drawing from the cases that we are seeing and some of the anecdotes that we're hearing from our colleagues, is to really be thinking about the ways in which what we know about trauma-informed care can be implemented and enhanced and really put in place in the context of what we're now doing around the changes in obstetric care and in mental health care delivery. So telehealth is really, really important as a part of what providers can do. So I think a lot of times we've wondered, especially in the context of mental health care delivery, to what degree is the video important or not? And certainly for components of care, or when video isn't available, we can do great work even still by connecting with our patients over the phone. But adding the video really can make a difference in terms of communication and engagement and connection. So the degree to which that's possible, it's important to try to add that into care. But nonetheless, having our visits occur in this altered way, having to wear masks when we are in each other's physical presence, having to maintain physical distance can all really limit the availability for nonverbal cues and nonverbal reassurance. And so it's really important then to use the faculties that we do have, so engaging in direct eye contact, using really clear and supportive verbal communication. So being thoughtful about tone, thoughtful about volume, thoughtful about eye contact during speaking, but also while listening, to really engage and almost overemphasize the goal of connection when able. We're hearing from folks that people are finding creative ways to either put photos of themselves on their PPE or to wear their ID in such a way where their full face when the photo is taken is visible, to draw on a smile onto their mask. And in some settings, we're even seeing the use of clear, not open, but clear material placed where the mouth is to engage people who may rely on reading lips, but also to engage nonverbal communications like smiles that we all are missing. Next slide. The other thing we can do is really be thoughtful about preparing patients for what's about to happen. I think this is a really important component of trauma-informed care, and we'll talk a little bit about some of the principles in a bit, but thinking about how do you describe in detail what's going to happen during a telemedicine visit. For some people, this may be the first time they've engaged in telehealth. And what will it be like to arrive at the hospital for a prenatal appointment or for labor and delivery? Who will be there? What will it look like? What's changed now that we are engaging in all of these precautions? And then being, proactive with patients, thinking about who are their support people, and then what's the backup plan if that support person isn't available because of so much of what's going on. For example, if the support person that they had planned becomes symptomatic and isn't able to join them, or isn't available because of the timing of the onset of labor. Also thinking about for those who have engaged birth partners or who had the plan to have a doula, for example, or were wondering if they could, to work with their doula service or their partner to think about an option for video conferencing or video chat. Some facilities are able to actually help support families with devices if there aren't, or chargers or things like that to support use of that. And if not, so kind of thinking through like what problem solving a little bit preemptively when you can, and reassuring women that the visitation policies have evolved. So I think a lot of what's happened and what I'm hearing about amongst my patient population is that there's this fear, especially around the media concern that was raised in the very early part of the response to the pandemic that had very, very restrictive policies. But actually over time, some of these policies have evolved, and many birth centers have tried to be as thoughtful as they can while maintaining safety for their staff and for their patients. And so the policies are evolving, and patients may be operating under some misconceptions about what is or isn't allowed. And so it'd be helpful to kind of revisit that very, very explicitly as early as possible and along the way. And one of the things that I have seen come up more than once in the context of all of this sort of adaptation of prenatal care is really hearing about patients who are considering delivering outside the hospital. And so in our team and amongst our colleagues, we still maintain that hospitals are, especially in Massachusetts, hospitals and birth centers are the safest settings for delivery. And so if a woman is considering home birth, just having a thoughtful conversation about the risks and benefits, especially because emergency care and rapid access to emergency care is different now in the context of COVID. And also when thinking about the counseling around things like psychotropics, for example, making sure that a family, if they're considering home birth, is aware of the risks and benefits of the availability for neonatal monitoring and so on. Work-life balance remains a challenge no matter what, I suppose. So, and the other thing that we are seeing, and I think the one thing I didn't highlight explicitly about the case a moment ago is that the woman who I described was a woman of color, and she was coming from a community where COVID-19 had really been had been more prevalent, and sort of the cases in her family sort of highlighted that. Communities of color have been disproportionately affected by the pandemic. And I think as we're seeing in so many different ways across a variety of different settings, both in healthcare, in the workforce, in a variety of places, that these inequities that had already existed in our society have been exposed and been widened. And so thinking about the trauma of the labor and birth process has to be overlaid on the context of the sort of longstanding and somewhat subacute or newer racial trauma that's existing in this context of disproportionate cases and disproportionate healthcare. And so that we have to be thoughtful about the fact that there is some mistrust that's that overlays medical care when they're in the context of this longstanding racial trauma, that there is grief that may be happening in the context of loss, acute and recent loss, and maybe older loss. There's fear. How is my care going to be different? Am I going to get the safest care? If my providers don't understand me and where I come from, will that affect how they're able to care for me? And so and it's just important to be aware of those dynamics in the context of thinking about exacerbation of further traumatic reaction. Next slide. And so I think it's important to be thinking about all of these issues, and I'd like to just kind of highlight with another case that we saw a few other components of all of this. So we're hearing, as kind of highlighted in the poll earlier, that across the state, people are hearing more about mental health symptoms, and the same thing that you are experiencing as well. So in this case, we ended up seeing for a face-to-face evaluation as well. This was a woman who her due date was right at the end of March. And so she had been sort of planning she was a dancer, and she had been working in studio, teaching classes, choreographing routines, performances, right up until her plan had been to perform and teach right up until about a week before her delivery, and then return 1 month postpartum to her work. She had a care plan in place where her family was going to come from abroad and take care of her baby and her older child. And within a few weeks, her entire plan was completely impossible. Not one component. The family who was supposed to come visit and help care for her children were not able to travel safely. Her profession may not ever look the same is what she fears. And so all of these things were taken away from her. And so when she presented, she was contacting her provider over the phone or for telehealth, at 2 weeks postpartum. And the provider was really alarmed because she was incredibly disconnected during the video visit. She was irritable, she was sad, and she referenced a prior mental health history. And so the provider felt really concerned and so requested our evaluation. Upon evaluation, it really was striking because this woman actually didn't meet any criteria for any major mental health condition other than, in fact, grief. She was experiencing this immense grief about the loss of what she had envisioned for her postpartum period, what she'd envisioned for her growing family, and what she'd envisioned for her professional life after. And it was really important for us to kind of think a little bit about how, while this would otherwise not be a pathologic condition, this is incredibly more common in the context of this very, very unusual circumstance. So a sort of an understandable reaction in the context of very, very atypical circumstances. Next slide. And so in this, as we're thinking about how do we as providers, both in a variety of settings, mental health providers, obstetric providers, women's healthcare providers in a variety of settings, think about the fact that these conditions, this pandemic really has introduced an increased risk for mental health symptoms and conditions that may or may not be associated with formal diagnoses, but are certainly burdensome and are certainly impacting our patients. And so for women who don't necessarily meet criteria for a mental health condition or a diagnosable illness that we would pathologize, it's still really important to have space to discuss concerns about labor, birth, and the postpartum period. What are the expectations that were in place? How have they been altered? What are they fearful that can never happen again? All of those things, there has to be some space to discuss those. And also an opportunity to discuss what are the sources of support. in the context of social distancing, we still have ways to connect or have support in place, but they're really, really limited. So having some space to have those conversations preemptively. Also reminding patients that there are mental health providers available. So despite telehealth, despite social distancing, telehealth is still an important modality, and we're all using it. And we actually therefore have still quite the ability to connect people with professional support in addition to peer and group support. And that mental health providers can treat mental health conditions. Sorry, next slide, thank you. For women with mood disorders, they are certainly at greater risk during this time. And I think one of the things that's really important is finding ways to explicitly emphasize daytime structure. So routines and structure can be really helpful. As we know, the perinatal period is fraught with sleep disruption, both prior to delivery and certainly after in the context of caring for a newborn. Now more than ever, when people are also working from home and homeschooling and everything kind of taking place within the home, often daytime routines can erode a little bit, and having a fatigued early postpartum parent, certainly that exacerbates that. Also, given that we're maintaining physical distance, we have to be intentional and explicit about our efforts to maintain social connectedness. And so that's important as much for, if not more, for women with mood disorders as it is for all women. There are parenting groups, there's lactation support, there are a variety of virtual support groups that are happening online, and we have the ability to help facilitate those connections when, if you were ever to call us about these kinds of things. A lot of connection is happening also through social media, Facebook groups, and so on, that can be really, really helpful. And then certainly for mood disorders, it's really important to make sure that treatment remains intact. So if there was treatment going into the pregnancy, make sure that's preserved. If symptoms are exacerbating, make sure they're getting evaluated, and certainly medication and psychotherapy when indicated. Next slide. For anxiety disorders, certainly, especially if we're able to screen increasingly, then it's important to also have, make sure that women are, there's this strategy that you see much more in people who have high anxiety, where there's this continuous seeking of information. And there's this risk, especially now, where there's this onslaught of information and from so many different sources, especially around some of these very high anxiety-laden topics, that patients may be engaging in kind of an information overload. And so having that conversation about what are reliable sources, what are the sources that make you feel more reassured, well, how about just choosing the ones that you feel more reassured by, rather than going to the 10th and 12th and 20th page of the Google search, where things get a little less reliable. And also thinking about limiting the amount of intake of content. And then also encouraging patients to explore resources like meditation or mindfulness skills, anxiety management skills, a lot of which are available online and increasingly available affordably, so through apps and so on, some of which you'll see in the handout that this is drawn from. Next slide. We also, cognitive behavioral therapy is an incredibly useful type of therapy, and it can be sometimes hard to get immediate referral through in-person visits, but it's certainly available through telehealth. And also there's a self-guided workbook that we recommend a lot by Dr. Pam Weigartz, who was actually instrumental in developing some of these materials that we're presenting from. And she wrote the Pregnancy and Postpartum Anxiety Workbook. And so this is something that we really recommend for a lot of folks, and especially now when not necessarily being able to engage in in-person cognitive behavioral therapy right away is an option. This is a very accessible strategy. Certainly, I think an important part about for folks with anxiety is fostering a sense of control where it's able, and empowerment and agency, and so involving women in decisions about their care ahead of time, and potentially considering medication alongside the psychotherapeutic modalities. Next slide. For women with trauma-related disorders, it's really important to be aware of signs of prior trauma. Some of the things that might be noticeable, even if you're not sure about the history itself, avoidance of prenatal care, or intermittent attendance at appointments, extreme fear around procedures, needles, IVs. Sometimes that's a standalone phobia, but sometimes it's in the context of trauma and other fear that may be in place, extreme sensitivity about, or more sensitivity than would be expected about bodily exposure, or having a strong reaction when during physical components of an exam. Next slide. And so while we like to think that we know about as much about our patients as possible, it's really, really important to recognize that trauma is so prevalent that really we should be thinking about trauma-informed care as something that's applied universally. Kind of like we think about universal precautions for infection control now more than ever, it's important to be thinking about trauma-informed care as also a set of universal precautions now more than ever. Next slide. Broadly thinking about trauma-informed care, certainly understanding that if we sort of take the position that trauma is incredibly prevalent and there's a high likelihood that either a patient or a provider or the combination may have different exposures to trauma, safety has to be at the cornerstone of trauma-informed care. But sort of one of the next important principles is really trustworthiness and transparency. So as we've talked about kind of throughout, having a very, very open set of communications about what to expect, what the care is going to look like, how care can be amended in the context of unique needs for a patient and how it can't be, being transparent about that and engaging in a conversation in which there's mutual trust that's developed. Next is peer support. So thinking a little bit about how can peers be engaged in supporting a patient both during the context of their care, outside of their care. Peer support is part of trauma-informed care. I think it probably should say social support. So it may be peers, but it may also be family, it may be natural connections. Collaboration and mutuality is an important component as well of trauma-informed care, really thinking about the patient as part of the team and thinking less about what is the usual sort of the historical view of patient and provider in a hierarchical setting, but much more about kind of a laterality and mutuality in care. And then also empowerment, voice, and choice. So finding ways to incorporate patient voice and staff voice and provider voice in the way that care is delivered, and also opportunities for continuous feedback and then choices where they're feasible for care. And then again, acknowledging as we talked about with the second case, thinking about there's this constant sort of cultural and societal context around which trauma is more prevalent in certain populations, and there have been disparities and inequities that have been part of a more complex systematic set of traumas that people have experienced, and that's also part of the exposures that we're contending with and trying to challenge and undo over time. Next slide. So if somebody does have a trauma-related disorder in the context of screening, in the context of increased suspicion, you have a conversation about it, it's important to be thinking about screening for safety prior to a virtual visit or a telehealth visit, during the telehealth visit, also in the context of in-person visits, thinking about who may be in the room that you can't see in the video, who may be able to hear, who you're not aware of, and being thoughtful about asking the patient ahead of time or at the beginning of the visit, does she feel comfortable discussing whatever the topic is. Having trauma responsive approaches to being able to offer autonomy. So there may be topics that you can say, okay, well, if we can't talk about that today, that's totally fine, but let's make a plan to talk about that topic in another way. What would be a good way to do that in the future? If you're in an in-person visit, thinking about asking permission prior to physical contact, if there is a procedure that's necessary or an examination that's necessary, narrating the steps in advance and then as it's going to make sure that you're kind of alerting the person to what they can expect, especially if there's components of it that they may not be able to see during the exam. And then certainly, of course, maximizing privacy whenever possible. Now, recognizing that in the context of virtual care or in telemedicine, we may not be fully aware of the level of privacy that is or is not present. So just being really explicit and trying to facilitate that and preemptively asking people to ensure that when able. So, ahead of the visit saying, find a quiet space, find a space where you feel comfortable talking to your provider for the expected amount of time. Next slide. Again, involving women in the decisions and offering choices when feasible, but recognizing that may not always be feasible, especially in the course of labor and delivery care, where the clip may be quicker and there may be times where things are not optional. Explaining what, before the labor process, what types of emergencies could arise or might not arise, how that's going to look in the context of newer procedures. If they've had a prior delivery, things could look entirely different now than they did with their prior experience. Being thoughtful during the course of delivery or during any care, actually minimizing directives, commands, loud voices, and then again, just being aware of nonverbal communication. I mean, this is again, thinking about that as a universal precaution that we talked about earlier, but also especially in the context of someone who already has a trauma-related disorder, positioning, eye contact, sitting down, making eye contact during conversation and even during nonverbal communication. Next slide. For women with substance use disorders, it's really important to acknowledge that care is a bit different now for substance use disorders. So we're certainly increasing, taking on treatment in a different way. So the bar around accessing treatment in some ways is lowered because there are, lower than you might expect, because there are still virtual care options for opioid treatment programs and rapid access programs, as well as detox and CSS and other modalities where even in the context of the pandemic, they're still able to access some types of care. Other types of care are harder to access, but there are treatment options. We at MCPAP for Moms have expanded our services, and we have a substance use project manager who's able to really help facilitate conversations about unique needs for patients. We are still encouraging the use of medications for opioid use disorder in the same way that we would outside of pregnancy and during pregnancy prior to the pandemic. We are thoughtful about the fact that that we need to take a harm reduction model to care, and so the more rapid the access to treatment, but still trying to minimize barriers. There are roles for things like drug testing, but we're increasingly loosening and recommending loosening those expectations because we're having less and less physical contact during the course of care. So all of these things are things that we can be thoughtful about, especially for women in the context of substance use disorders. What we're seeing also, though, is an increased rate of using substances like alcohol. While it may be harder to obtain illicit substances, alcohol is now easier or relatively easy to obtain, and so we're seeing increased risk around that. So asking women, especially those with a history of substance use disorder, how are they coping? Have there been any lapses or relapses? And what were the triggers? And trying to think a little bit about how to problem solve around those is really important. Next slide. All of the treatments that we would recommend for use in pregnancy for opioid use disorder remain available. Virtual support through 12-step and mutual help groups like AA, Alcoholics Anonymous, NA, Narcotics Anonymous, and Smart Recovery are available. It's actually quite amazing. I had a patient say, I got to go to a meeting in Sydney, Australia, and I would never have a chance to go there. And like there was almost an opportunity here to be thinking about different access to treatment that someone might not otherwise engage in. The Journey Recovery Project, which is sponsored by our colleagues at DPH and the Bureau of Substance Abuse Services, is an incredible resource that has a lot of peer-to-peer as well as professionally oriented resources. The Mass Helpline is still available and active and updated. And we're thinking, often about kind of what is the role of drug testing. I think we're loosening our thoughts about this and really trying to make sure that we're not making drug testing a requirement for treatment, but much more an adjunct or a way to support treatment and to demonstrate engagement and adherence. Next slide. So thank you so much for attending our webinar. We're here, we're happy to take questions. We have a wonderful team, some of whom are on and some of whom weren't able to join, but we thank you so much. And next slide, you can just have some time for some questions.
Thank you, Leena, for your presentation. I always enjoy hearing you talk. So does anybody have any questions for Leena or I? We're happy to answer any. And you can either enter them into the chat box, or can people unmute? I think they need to enter them into the chat box, Sarah, or can people?
If they raise their hand, I can unmute them.
Yeah, or you can raise your hand and Sarah can unmute you. We'll just give it another minute, and if not, we can. Leena, I have a question for you, actually. When I'm just curious to hear your thoughts, and when you're doing, you talked a lot about the challenges with doing all this through, trauma-informed care, and kind of how it can be challenging to do that in the context of COVID and such. Has there been anything you found that, in talking with women, either professionally or in other circles we all move in, where we're working with women with experience outside that? I'm curious to hear if there's things that you've been hearing from people that they say, oh, this made a really big difference. Like that my provider did this and wow, it really helped, or something like that. I'm curious to hear about, just what you're hearing from women. Like, doesn't have to be formal based on data, but kind of, just experientially.
Well, what I'm seeing, actually, I guess it's much more what I'm observing is I just am seeing providers that are going like sort of above and beyond. So in that case that I just described, the second case, the provider who had provided her prenatal care knew that she wasn't going to have a support person. And so actually arrangements were made within the care, or it just kind of happened on the fly, where somebody from the care team who'd been part of her prenatal care actually came to the hospital even when they weren't working, and they ended up being a support person for her. And so there are these ways in which I think people are really trying to think creatively about engaging supports where things have been taken away, that I think has been incredibly useful. And I think the fact that patient then called her same prenatal care provider despite having had what was really a traumatic experience during her delivery reflected that rapport and that alliance that was built because of her belief that person was really trying to provide good care and support her. And so I think that's probably the common theme amongst all of it, is when a woman is able to perceive that despite the complexities of the time, care is really being attempted to be patient-centered. I think that makes a big difference. I've also heard some stories where that wasn't the case and it didn't go as well. And so I think that's probably the most important theme. I think the connecting theme there, or thread.
Yeah, no, I agree with you. That's been my experience too. And like, as I described, that pediatrician who called was like, we're going to start screening. How do we do this? Because we don't want women to fall through. And I agree. And I think it speaks to the power that frontline providers who are seeing these women have. And I think even if and I don't know that it's about, I don't think that you necessarily have to do more. A lot of it's changing how you say it in a way that's patient-centered. It doesn't necessarily have to be adding stuff, but it's kind of rephrasing stuff to not be like, why are you late? But must have been hard to get here.
Right.
How did you manage to do that? You know what I mean? A lot of it's just doing it from a different perspective rather than I think sometimes we think, oh, we have to add more, but I don't know that we have to add more. It's kind of just rephrasing it sometimes. So we do have a question. So the reality, I'm just going to read it out here. The reality for support in L&D is not so great. They do get one support person, but they are kept in the room. The vignette of the COVID positive woman is really an issue. How are they supposed to learn to care for their babies while being kept separate from them? How can we prepare them without adding to the trauma? That's a really good question.
This was a huge challenge, and it was sort of, I think everybody's a little bit learning as they go all at the same time. So I think, Nancy, if you have thoughts about
that. Feel free. You're on a roll. Go ahead. Keep going.
But I think, one of the things that I thought was really useful was actually, for that particular case, they were able to negotiate a little bit of extra time for her to stay in the hospital, I think another half day with the baby in the room, to be able to just learn care. But it was very, very hard. And I think some of it is also in thinking about what will the supports be postpartum? So once they've gone home, who's going to be connecting with them? And that may be a combination of efforts from the OB office doing frequent phone check-ins. A lot of the practices that we're hearing from are increasing the frequency and shortening the time after discharge that they're calling and checking in with patients. And then I think potentially the pediatrics offices are also doing similar things, phone and telehealth check-ins that may offer increased support earlier. I mean, at this point, we don't have home visiting, but or not as often anyway. A lot of the home visiting programs are limited in their ability, but things like early intervention are still operating. So there may be opportunities to bring other support into the home virtually. But they're limited. But still, I think thinking creatively ahead of time about what might be arranged proactively or quickly after delivery. And Nancy, please, if you have other thoughts about it, I'm not sure I have all of the resources.
Yeah, no, I agree. I think EI is a great point because they, as I'm aware of EI from another project I do, and they are doing visits virtually. It's different, but they're doing them. So I think that's a great thing to think about, is referring to EI, and a lot of people are eligible for EI, and a lot of times a mental health, if someone experiences, a mental health or substance use disorder, that can also often qualify them for EI. So that's something to think about. And I think the other thing, this is kind of building on what you said earlier, Leena, that I think offering people choices, because I think part of what happens during stuff like this is all of a sudden so much stuff has been taken away from us, and that just inherently makes everybody anxious. Like you can't do all these things, and I think a lot of what happens when people have a baby is that there's so much you can't control. You can't control when the baby, anything about the baby, in fact. I was going to start naming things, but it's really like anything, like when they cry, when they poop, like anything, you just can't control it. And so I think, and then you have something where you can't even control your own environment. So I think like what you were saying earlier is giving them choices around when they're in the hospital. Like if there is choices about anything, offering them choices about, so it's not like, no, well, you can't do this. It's like, okay, well, you can do this or this. And it may be like a minor thing, right? Like, do you want to, when they are being discharged, perhaps like, do you want to see your baby 5 minutes before or 10 minutes before, whatever that can be, but just to sort of give them choices around whatever, because it helps people feel more autonomous and helps their self-efficacy if they feel like they can make choices around things. And then it may also help their self-efficacy of mother if they're at least given some of that. So I think that's the challenge, when all that's stripped away, and with COVID, it just is. And that's stripped away when you become a parent anyway, and that's just so much exponentially worse during this. So I think that's another, important piece. And then also offering them resources and letting them know, like acknowledging, I think commiserating with them. Yeah, because I think sometimes we say, oh no, it'll be okay, or oh no, like really validating them and acknowledging the loss. Because I think sometimes we don't want to do that, and then because it's hard for us, we don't want to sit in that vulnerability with the patient. But I think if we can sit in that with the patient and just be like, yeah, this is a loss, like acknowledging the grief, like the other case you described, Leena, and then kind of saying, like sitting there with them, acknowledging it, commiserating with them, and then kind of saying, well, these are the things you do, offer them some choices and let them know what they can do, which may not be what they could have done before, but there still are some things, and kind of whatever they can grab onto for some sense of self-efficacy. Yeah. Do we have any, I know we're just about at time. Are there any other last questions before we end?
Do you have any tips that sometimes when we get calls on our of providers really unsure, like because there's a lack of screenings, like how to like start that conversation and really kind of get truthful kind of responses from their patients? Because sometimes we get this kind of like, I don't know if it qualifies for a MCPAP for Moms call, especially given this circumstance.
When you say it doesn't, you're saying like framing the screen in a way such that the patient's going to answer in a way that they feel safe and comfortable to answer the questions. That's what you're asking. Yeah. I think this is a really good question. So, and we've seen this, like we actually did a study recently, and we had a practice, it was a pediatric practice that served a mainly publicly insured population. And literally like we had nobody screen positive in the study. We know that there's like, just from this data, like the stats, there's no way that no one screened positive. I think a lot of it was that it was as Leena talked about, like a lot of people don't trust the system. Like they, and they're worried about DCF taking their baby away. There's a lot of reasons, really valid reasons why people are worried about this. And I think that the way you frame the screen is really, really important. I think it gets back to a lot of what Leena was talking about earlier with doing this with a strength-based, trauma-informed, trauma-responsive approach, another way to say it. And I think, you know, one example is, you know, I think like, you know I had an example of someone recently who was in a practice and they were like, oh, you passed the test. I actually got screened myself for like the PHQ-9 at my PCP visit. And when I finished it, she said, you passed. And I was like, really? I was like, you know, like that. And so I think like not having it be like a duality where it's like, okay, you fail and you pass. Like these are things that we want to, I think coming at it from, we're curious to know how you're doing and we're here to help you. And we're curious to know how you are. And also to explicitly ask if they have any concerns about it and going at it in a strength-based approach. And it's not a dichotomy of either you pass. And it's amazing. Like this person was a lovely MA who was really nice. But she just like thought that, you know, that's how she was thinking of it. But it's a continuum, right? Like we all struggle in different ways. And we're trying to, you know, the reason we're asking these questions is we want to know how people are doing. And we want to be able to support them. And it's not like either you're this or you're that. It's, we all have, and I think acknowledging that, like we all have challenges mental health wise, we all experience things, and that, you know, this is a way to figure out what support you may need, and going at it from kind of that standpoint and acknowledging that we all experience these things. So do you have anything to add to that, Leena?
No, I think that was a really useful illustration to think about. It's not passing or failing, but it's engaging in the conversation.
Yeah. So I think that's like, when I think people, they're trying to do their best, you know, and I actually gave her the feedback and she's like, oh my God, you're totally right. Like, I never thought of that. I couldn't help myself, but you know, so I think it's like things like that. So I know we're at time, it's 1:15. So thank you all for attending. Thank you, Leena, for presenting and Beth for moderating. And thank you for attending. And I think we'll wrap up. Thanks.
Bye, everyone.
Bye-bye.